so much, Justine, and thank you very much for the invitation, and good morning, everyone. Thank you very much for taking the time out this morning to attend this. I do hope you're going to find it. You're going to take something that's of interest and use to you from what I'm going to talk about for the next 30 minutes to 3/4 of an hour or so. I'm going to focus on work I've been involved with that's focused on those who've had a bereavement following an alcohol, other drug or gambling related death. Just to say a little bit about me, I'm a social sciences researcher with a career that's spanned over 30 years now, and I've variously worked in the NHS, in the academic sector and freelance. These days I work part-time. I work part-time for the Centre for Death and Society at the University of Bath, and then I work part-time as a freelance consultant. So even though there's an overlap between those two things, they are very separate. The primary focus of my work over the years has been on substance use and related issues and how they affect children and families, and thinking about ways of raising awareness about their experiences and the responses that are needed. I've done a lot of UK and international work, and I've published very widely, myself and with a wide number of colleagues over the years. And also over 10 years ago now, I helped establish AFINET, the Addiction and the Family International network, and we currently have over 900 members from over 55 countries. So that could, so this may be a forum that's of use to you. You can, the link to our website is there on the slide. As Justine said, my slides will be shared with you after this. So you can look on the AFINET website, where there will be various things that you can attend and see and get involved with, and also a couple of things that will require membership, which is free. I'll say a little bit more about that later. So I'm going to focus on two large qualitative projects that I've been involved with, a particular strand of my work over the last 10 to 15 years. And then I'm going to talk about three implications, three ways in which those two projects, in which we're trying to take the findings from those projects to try to make a difference, to try to improve support, thinking particularly about those who've been bereaved by substance use or gambling behaviours. And just to say that there will, Justine very helpfully mentioned about self-care during these sessions. Just to say, I will be sharing, making comments about things that have come up in our kind of research, and sharing some quotes. You may find some of what you hear and read upsetting, so please do just be aware of that and look after yourself. So the first project, actually both of the projects I'm going to be talking about were funded by the Economic and Social Research Council, and I was involved with both through my links with the Centre for Death and Society at the University of Bath. So the first project considered specifically people who've had a bereavement through substance use, so that's alcohol and or any other drug. And in terms of thinking more broadly about substance use related deaths, we know that these are highly prevalent around the world. They don't seem, the numbers don't seem to be abating, and in some cases, they're increasing, and they're deaths that have, large and wide-ranging social and public health impacts that, that don't just affect those who are directly, related to the person or the people who have died. The research, including ours, is helping us to increase our understanding of what is different, unique, and nuanced about this type of a bereavement. and hence what the implications of that are for help seeking support. This can be a group of people who, because of their experiences, can find it incredibly hard to seek support, but also it's fair to say the support is rarely there in the way in which it is needed. I know there are exceptions, such as the new service in the Nottingham area, and also addiction family support and work elsewhere, such as in Scotland. But by and large, this continues to be a largely ignored and hidden kind of issue, where the amount, the quantity and quality of support does not meet the demand or the specific needs, and there's also rarely thought given to the very wide range of people who can come into contact with those who have been bereaved in this way, and so have the potential to kind of offer some kind of help and support and to make a difference. So this first project, the Understanding Bereavement Through Substance Use project, as I said, we completed it about 10 years ago now. We did over 100 interviews across England and Scotland with adults who've had this type of a bereavement. They were long interviews, usually lasting about an hour and a half, sometimes longer. We also did a number of professional focus groups, and then we convened a working group, a multidisciplinary working group, also including some lived experience, and we developed good practice guidelines, and I'm going to say more about those towards the end of my session. And we have also published widely in terms of books and papers as well from this piece of work. It's actually not on the slides, but I will separately send to Justine a link on the University of Bath to a project page where you can read more and access some of our references and other publications about this particular project. But what this project did was it has contributed to other recent kind of work, including work and clinical experience from Peter Cartwright, who convened the working group to develop the guidelines, and also a large drug-related death project that finished about a year or so ago in Norway. And so from those three projects, there has been other work as well, but these are three that I'm most familiar with, and perhaps most recent is we are increasing our understanding and knowledge about perhaps the characteristics of this bereavement, what might really stand out and be pertinent, and what can perhaps make them different and potentially very difficult and complex bereavements as well. And you'll see the middle column here is 5 overarching themes that came from the project that we did. So thinking about the living with the possibility of death, or what can commonly be called anticipatory grief. Thinking about engagement with official processes, which can be very wide ranging, so can include pathology services, the emergency services, police investigations, the coroner's court, for example. Also, you probably won't be too surprised to hear that stigma really stood out as a theme. Also, the impact that this type of a bereavement often coming at the end of many years of of living with someone and knowing someone who is actively using alcohol and drugs, and so this has the capacity to really affect, block, impede, complicate, exacerbate grief, and the ability to process that and to find a way forward. And then finally, we heard about the both the lack of and the poor quality support that many of our interviews encountered from a very wide range of network of people that they may come into contact with, for example, official processes, but also thinking about things like funeral directors, counselling, and a wide range of other people and places as well. So those were the 5 themes, or 5 of the key themes that came out of this particular project. It's fair to say that interviewees did share perhaps positive encounters and more comforting experiences of having a bereavement in this way, and their interactions, with others and how they were treated, but that poor treatment and poor experiences were far more commonly communicated to us. And quite often, in some of these quotes, I think, give you an indication of that, as to actually really quite extreme and shocking experiences of how people were treated as well, and how that could affect them in really kind of negative long-term ways as well. So that's the first project to give you like an overview of. The second one is more recently completed, and it's our Voicing Loss project that's focused on how people specifically experience the coroner service in England and Wales. And there's a policy aspiration that's been in place for quite a number of years now, for bereaved people to supposedly be central to, at the heart of, the coroner service, and to where they may be an interested person in the investigation, like an inquest, to have certain rights. And so, using that as a starting point, we wanted to explore actually whether that aspiration was the reality for bereaved people. How did they experience the coroner service? Did they feel at the heart of it? Did they feel involved? Did they feel able to participate in the process in the ways in which they are supposed to be? They were supposed to be able to, and perhaps where there were gaps in that, what could be done to help them feel better supported and included and able to participate in the process. Again, this was a large interview-based study where we recruited from a very wide range of sources. I will say that voicing loss was not specific to substance use. We talked to people where there'd been deaths in prison or in police custody, in hospital, mental health deaths, road deaths, death by suicide, and a wide range of other deaths. But probably about a fifth of our sample, there had been some involvement of alcohol or drugs in the death. And also we worked very closely with the charity Gambling with Lives, and so we did talk to a number of people who'd experienced the coroner service following a gambling related suicide. So we talked to 89 bereaved people. You can see a bit of a summary of perhaps some of the key demographics of our group of interviewees. Just to explain, obviously don't know how familiar attendees are with the coroner service, so just to explain a couple of acronyms and terms at the bottom of the box here. PFD is Prevention Future Deaths, and this is where a coroner must write what's called a Prevention of Future Deaths report if they feel that action could be taken by an individual or an institution to prevent future deaths occurring. Those reports can be sent to, for example, a government department, a police force, a mental health trust, a hospital trust, for example. A coroner can list actions that they believe need to be taken, but they cannot give specific recommendations, and they certainly cannot make any comments relating to sort of blame or accountability. So the reports have to be, very carefully worded, and the whole prevention of future deaths process, I think there's very mixed views and feelings about it, largely because there is a lack of follow-up of the reports, and whether the organisations respond to them, whether they take the suggested actions and so on. So, you know, there's very little follow-up and kind of recourse to the process. And then the other term down there is Article 2. And this is where, like an inquest may have a slightly broader scope. So for the most part, an inquest is a fact-finding exercise to establish who the deceased person was and how, when and where they came by their death. But in some cases, there may be a slightly expanded scope to consider more the circumstances of how someone died, and for some of those deaths, particularly those perhaps in a state institution such as an immigration centre, police, or a prison, or an inpatient mental health facility, there is, you know, an Article 2 inquest may be engaged because that relates to Article 2 of the European Convention on Human Rights and the right to life. As part of Voicing Loss, we also interviewed a large group of professionals listed here. And so some of the findings from Voicing Loss, again, as with the previous project, interviewees did share some positive experiences of being maybe well informed in a timely manner, being kindly, compassionately, respectfully treated, feeling that the coroner service cared and was fully committed to properly scrutinising the death. They felt that the person who had died was sensitively part of the investigation and the proceedings, and some felt that the process of the investigation and the outcome did bring them a sense of catharsis and maybe peace and relief, and that they had the answers that they wanted to get from the process. And there's a couple of quotes to illustrate that here. But unfortunately, again, negative experiences were much more commonly communicated in interviews that were, again, you know, long, an hour and a half, a couple of hours in length. And we did, you know, the majority of interviewees shared at least one thing that was maybe poor and negative about their experiences, but in actual fact, you know, many of those, you know, gave a list of things that they felt just, you know, weren't right for them throughout the investigation and the inquest. And again, actually saying they were negative experiences is probably a vast understatement in terms of the choice of wording, because again, we heard some really shocking and upsetting examples of what people had to say. And again, they covered the timing and, you know, way information was communicated to them, communication much more widely, how they were treated, how they were perhaps, you know, sometimes ignored and silenced throughout the investigation and at the inquest hearing itself, how they felt that the person who had died and should be supposedly, you know, the focus of the investigation, and, you know, the inquest, those people were not respectfully included and talked about. And as a result, some of our interviewees did not get the answers that they wanted, and they felt there were often missed opportunities for learning from deaths. And some were telling us that they knew of other similar deaths that had taken place, for example, in the same institution since their loved one died. And you won't, you know, given that, you won't be surprised to hear that our interviewees talked a lot, often at length, about how they had been affected by these poor experiences. They felt that there had not been what they wanted, which was justice for for the deceased. They experienced a huge amount of distress and often re-traumatization, both during the investigation, but particularly at the inquest hearing itself. They may have developed or had maintained mistrust that they already held in our, valuable societal institutions, such as, the NHS or the police force or the prison service. And as a result, many talked about a long-lasting emotional toll in terms of their physical and mental well-being, and delayed or complex grieving, perhaps even some going as far to say that they didn't think that they'd ever be able to, properly get going with the grieving process. And, this is a group of people who the majority or a large number had waited over a year from the death to get to the inquest hearing, and some of those had waited several years, up to 3, 4, 5, 6, 7 in a number of cases. And just to add something, I said that a fair number of our interviewees were involved with the coroner service following a substance use or a gambling related death. So I was just having a think about whether there was anything maybe different about this group to add to my presentation this morning. And I certainly think there are perhaps particular features of the actual or the perceived stigma that our interviewees experienced both within and outside of the coroner's court. The media intrusion and the nature of the reporting certainly came up. A feeling that not having perhaps the substance use or the gambling included in the coroner's final record of the inquest and the final death certificate meant that perhaps those kind of data were not then carried through to so-called official statistics, and some felt that that was an oversight, and again a missed opportunity for broader societal kind of learning about the prevalence and impact of these deaths and the need for something to change. And specifically with regards to gambling, a number of those that we talked to felt that the gambling was overlooked completely by the coroner, with no effort to perhaps consider the role of the gambling industry. And so the coroner was having an inquest that was much narrower in scope than our bereaved interviewees were hoping for and wanting. There have been a couple of high profile, more recent examples where actually gambling has been included and more specifically considered, and consideration of the potential impact kind of that, but there is certainly a way to go with that. So what are some of the reflections from our Voicing Loss project? I think first is that the expectations and hopes that our bereaved interviewees had of the whole process rarely matched the reality of what they experienced. And I think some of that, or perhaps a lot of that, is down to the information and communication passed on to bereaved kind of people. I think there were missed opportunities perhaps for coroners teams, perhaps others as well, to clearly and consistently explain to bereaved people what an inquest is, but importantly what it isn't, and to explain perhaps what their rights are within the process, and for example letting family members know that they are able to ask kind of questions or potentially read a statement at the inquest. Some didn't know that. Some that did were perhaps then surprised when they weren't able to have certain questions asked, because they didn't understand the scope of the inquest. That hadn't been communicated to them. So they were submitting kind of questions, expecting answers, not actually knowing that the questions weren't those that could be answered because of the scope of the inquest. So that's a key finding. I think further, where bereaved people were included, were treated well, it could really make a positive difference in the short, but also importantly in the long term. But then similarly, where there are poor experiences can also make a difference in the opposite way, and kind of often with really serious, long-standing and far-reaching consequences to grief and to physical and mental well-being. But I think all of this, our findings also have to be taken in the context of the pressures and struggles that the coroner service is facing. As some of you may know, it's a localised service, and so there's wide variation in the staffing, in the funding, in how it's organised, perhaps in the quality even of the coroner's court and the facilities, the staffing issues. You know, coroners are often and their teams are facing, you know, higher and more complex caseloads that then has an impact on perhaps the communications and support they are able to give to bereaved families. It's also, the coroner service is far from a government priority, and there are also, I guess, similar pressures within services that are like inevitably associated with the coroner's service, such as pathology and maybe toxicology services, also the likes of the newly implemented medical examiner service as well. And I think overall, by and large, the coroner, you know, the role and remit of the coroner maybe lacks clarity and maybe needs to be reimagined to better fit today's society and what is needed from death investigations. And I think maybe really perhaps our key headline finding, and maybe that one of the most upsetting ones, is that we conclude that the bereaved are actually kind of rarely at the heart of the process in which policy aspires them to be. It is not a service that is for the bereaved, far from it. And actually, added to that, we feel that the coroner service also lacks humanity, and that is a key change which could quite straightforwardly be changed. And so this is a link to our Voicing Loss website, where you will find like a wide range of outputs and information from the project. So like a number of research reports, some policy and practice briefings, information and resources for bereaved people themselves, which may be of use to some of you in your work. And also the Expert Insights is a series of maybe 20, 30, I guess you'd call them shortish kind of blog posts from a very wide range of people who supported our project and shared their views and experiences. So I do hope that if it's relevant to your work, that you take a bit of time to look at, you know, the website and find something of use and interest to you there. So I'm going to move on now, just for the little bit, just go through perhaps 3 things that I and, you know, various of my colleagues are involved with to try to make a difference. So to try to build on the findings from those 2 pieces of work and other associated work to try to make a difference. I've already mentioned from the Bereavement Through Substance Use project that we developed good practice guidelines. That's the little image there in the middle of the circle. We don't really have any hard copies available now, but the PDF is still publicly available, and that will be on the additional link that I'm going to send to Justine to ask to share with you all. So you'll be able to have have kind of access to at least a PDF version, and those guidelines are centered on the 5 key kind of messages that are given on the slide there. And the idea is that those key messages should be considered by any individual who comes into contact with someone who's had a bereavement in this way, because everyone, kind of all of us, have the opportunity and the capacity to do something, even something small, by way of help and support that could really make a difference for this group of people. And so the second, and this is then kind of really an overlap with the key thread of my self-employed work over my career, and it's work I'm involved with to adapt an existing brief intervention to hopefully be a resource to support families who've had a bereavement through substance use. And I'll just spend a few minutes telling you about the intervention itself, and then I'll tell you a little bit about the work that we're doing to adapt and test it to hopefully be something that can be used to support this group of bereaved people. So the intervention is called the 5-step method. It's based on the evidence-based stress strain information coping support model that is outlined in the diagram there, and it very straightforwardly talks through the stresses that affected family members, and this can cover alcohol, drugs and gambling, can face, the strain that can place on them, but that stress and strain can be mediated by good quality, targeted and relevant information, by supporting affected family members to think about and potentially adjust how they cope and respond to the situation, and by supporting family members to think about the support that they have and how they can potentially bolster and broaden the positive support that they have around them. So this is a model that's been around for over 30 years. As I said, it's evidence-based. We talk to several hundred family members from a range of international locations to come up with a theoretical model to describe the experience of affected family members, which is largely very similar around the world, with maybe nuance according to gender, culture, faith, whether the society is a hierarchically organised one or a community organised one. For example, it remains quite a unique model today, with a specific focus on its language and terminology and on affected family members in their own right. And the theoretical model is then the foundation of the 5-step method intervention itself. And you can see the 5 steps named here. When people are trained, we train them to work through the steps in order and to aim to complete the whole intervention. It's a brief, structured approach. It's also evidence-based in terms of ongoing research and evaluation. It's supported people, we ask that people do not use the intervention without being trained. And so training and supervision and ongoing professional development are guided by what's called a competency framework, which details the skills that are required to use the intervention correctly, competently, confidently, and with fidelity to the evidence base as well. We've developed our own family member questionnaire, which can be used to support the therapeutic work, but also as an outcome tool. And the 5-step method is widely used in the UK and in a large number of locations around the world, including some places such as Ireland, the Netherlands and New Zealand, where there are national schemes in place to support the use of the intervention. If you're interested in finding out more about this intervention, can I direct you to the AFINET website? The links on an earlier slide. You will find some information about the intervention there, but to access some of the resources you will need to join and become a member of our charity. I can always say a little bit more about that. I don't know how things are going in the Q&A, but feel free to ask more about that if you'd like, or indeed anything that I've been talking about. So just looking kind of quickly at some family member questionnaire data. I won't spend a lot of time going through this, but the family member questionnaire, what it kind of measures, aligns with the steps of the intervention and the underlying theoretical model. And some of the subscales of the questionnaire, you'd be looking for a drop in score over time to indicate positive change. Some of the subscales, you're looking for an increase in score over time to indicate a positive change. So given that, what this graph shows is that in all areas measured by the questionnaire, there is positive change, as we would expect. And that change for these nearly 900 affected family members globally, these changes are what's called statistically significant. So we have confidence that the change can be associated with the intervention rather than coming about by chance. So that was quite a long way round to saying that I'm involved with work to see if this intervention can be adapted to support those who've had a bereavement through substance use or following a gambling related death. I was involved in a small pilot study quite a number of years ago, before the pandemic, I think, to do an initial adaptation of the intervention and a small scale test with a treatment organisation in the Midlands. There was a paper published about that, and you can see here how we renamed the steps. We kept the theoretical model, we kept the steps the same, we kept the steps in the same order. Broadly speaking, the competencies for using the intervention are the same. Kind of obviously some of the content of the steps is different, but by and large, you would look at the two versions of the intervention alongside each other and you would see how very similar they are. And from that first small pilot piece of work, you can just see a couple of quotes here from clients who were supported by the intervention and were talking and interviews with me about what they found beneficial about it. I am now working with Addiction Family Support, who they used to be called Drug Fam, but they rebranded a year or so ago, and they have for many years included as part of their work wanting to support those who have been bereaved by addiction. They also support kind of families where the person with the substance use behaviours is still alive, and so their staff were trained maybe a year, 18 months ago, to use the original 5-step intervention, and that, my understanding is, that's going very well for them. And so I'm now working with them to do a further larger pilot of an updated adaptation, a 5-step for bereavement. So a small group of family and bereavement workers have received additional training. We updated the handbook again. We're not using the family member questionnaire because it's not appropriate, and it wasn't really easy to adapt. So we're using Addiction Family Support they'd already introduced the adult attitudes to grief scale, and we've developed our own questionnaire that more closely aligns with bereavement through substance use and the theoretical model that underpins 5-step. We have had a number of clients now engaging with the intervention. Some have completed their sessions, and Addiction Family Support are able to kind of offer, because we appreciate it's a brief intervention, and so there is the potential for those clients to then receive additional, perhaps peer group-based support after completing the intervention. Evaluation is underway. It's extremely early days, so I'm not able to share any more with you at this stage. I would hope we might have more to say perhaps later in the year or early next year. And I think our hope is that we will have, perhaps with, I'm sure some further tweaking will be needed, but we do hope to have an adapted version of 5-step that we can be quite confident in, and that we can think about offering elsewhere to other services. And so the third thing, I think I'm okay for time. So the third thing I'm going to say, and this is what I'm currently involved with part-time through my role at the University of Bath, and the project is called Supporting Loss. It builds on the bereavement through substance use and voicing loss kind of projects. We're just a few months into our 12-month grant, quite a small grant, but from the same funder. It's a partnership between us at CDAS, Centre for Death and Society at University of Bath, also the organisation Turning Point, and Birkbeck at University of London. And the inclusion of Birkbeck is because they were the lead for the Voicing Loss project. The aim of the Supporting Loss project is to develop an online toolkit, which will be hosted on the Turning Point website, to support people bereaved by substance use when the death is referred to the coroner. We anticipate the toolkit being able to be accessed directly by bereaved people, but also used by staff at a range of relevant services, perhaps to either increase their own knowledge and understanding of the coroner service, but also to then help them support their clients. We anticipate making the toolkit much more widely available and undertaking a number, small kind of number on quite a small scale because of the resources and things of the project, of monitoring and evaluation activities. What we're doing at the moment is we're running some knowledge exchange events. We did 2 yesterday. We'll be doing 2 more in early September. One of each of those pair events are with staff from across Turning Point. The other one of the pair of events is with bereaved people who we're recruiting from a range of places. As I said, we did our first 2 events yesterday. They went very well. We'll be able to use what people are sharing alongside our own research and ideas to then go away and develop the toolkit that, as I said, we'll be looking to launch early-ish next year, and then end the project by doing a small amount of monitoring and evaluation. I'm not able to share any more about this particular project, but I can, there will be more information available in due course, particularly much later in the year and early next year. So that's all I was going to share and go through with you. I do hope you found it interesting and useful. As I said, the slides will be coming around afterwards, so you'll be able to access things and read and find out more depending on what's of interest to you. But for now, I'll stop sharing. So thank you for taking the time to listen and see how lively or not the questions and chat is.
Oh, thank you for that, Lorna. It's, really interesting. Thank you for delivering the presentation. We haven't actually got any questions in the chat, so we'll just or the Q&A box. So we'll just see if anyone's got anything that they're wanting to put in now, because it's always a bit difficult to know if something's going to get covered in the contents of the presentation, isn't it? So sometimes. So, oh, we've got one come through. Let me just read this to you. So it says, in relation to your section on coroners, the quote suggests the depersonalisation of the deceased was particularly damaging. Do you think this is a kind of self-preservation in a service addressing often complex and distressing death? And then there's another question, will the toolkits be targeted at coroners to change this culture?
Okay, so that's a really interesting and quite complex question to unpick, the first one. I think we are, yes, I certainly take the point that coroners and coroners kind of officers perhaps do have to work in a particular way, and because of the nature of, you know, of their work, they perhaps do need to, you know, they do need to be independent, objective, neutral, and so on. But I don't think that is any excuse for things like, you know, getting the name of the deceased person wrong, not asking how the deceased person, how the family would like the deceased person to be, you know, referred to. Perhaps not taking care with how difficult information about the deceased life and death is, you know, communicated, and so on. So I think there is a need for balance, but I think we were finding that unfortunately the balance was skewed the wrong way. In terms of the toolkit, so you know, as with voicing loss, there is very little that we can do to change the coroner service. That is way out of our remit. I should have said though, for voicing loss, we did have the support and of the chief coroner who was in post at the time. The chief coroner then changed probably about a year ago, but we did have the support of the chief coroner's office. We did have the support of the Ministry of Justice, and we did have the support of a range of others, such as the Coroner Court Support Service, the charity kind of inquest, and so on. Actually, we had a huge amount of support for voicing loss, for which we're still incredibly grateful, as we wouldn't have been able, you know, the project wouldn't have been the success it was, you know, without all of that. So whilst we can share our findings, and we can raise awareness, we can't change things themselves. In terms of the toolkit, it's not focused for coroners. We will certainly do what we can to raise awareness of its kind of presence, maybe to coroners' courts and key other personnel and individuals, but then it's really up to them what they, you know, really what, you know, what they choose to do kind of with that. What we also want to do is, you know, we are aware that there are other resources out there. So there is, you know, the Ministry of Justice guide, for example, you know, there are other guidances and information out there. So we don't want to completely reinvent, you know, the wheel. But we know even with those other resources that are available, there's a huge gap in the information and the support that bereaved families get and have access to. So we want to try to fill that gap, thinking more specifically in the first instance about this particular cohort of deaths and people who are bereaved by them. So I hope that goes some way to kind of answering both of those comments and questions. Thank you to, I can't see all of the comments and questions. I can see some of them, so I can't always see who the names are, but that's fine.
Oh, thank you for that, Lorna. So we've got another question here that asks, is there any work underway or in scope for work or scoped for work to adapt these interventions for staff? Thinking of lots of our clients at high risk of substance related death with minimal family contacts, and relationship based work can leave a big impact on staff when a service user dies.
Yeah, that's another really powerful, important point, isn't it? Is the impact. And you know, we heard about that from the professional input into the bereavement through substance use project. Also, actually, you might have seen it was part of voicing kind of loss. It was actually an additional element, quite a small but additional element to the project that we weren't originally intending to do, where we interviewed 19 professionals from, you know, in a range of roles from a range of services and sectors who had experience of giving evidence to one or more inquests in their professional capacity. And so across that professional, and also some of the other professional interviews that we did, so that professional input from the 2 projects really reinforces actually the point that's being made about the potential impact that these deaths can have. I'm not aware of any work out there to perhaps offer specific interventions. I know actually we did hear about I think there's something called TRIM. Some of you may be aware of. It's a trauma-informed way of working that is used by the police, and I think in some prisons as well. And that is that's not specific to substance use, but is about offering a more trauma-informed based model of support to staff affected by a wide range of deaths that they may come into in the course of their work, whatever that kind of might be. But so I think the short answer is I'm not aware of anything. We don't have any plans at the moment within our current programme of work, and the funding that we've access to, and things to perhaps think about adapting 5-step for professionals. But it's a very interesting idea that I will certainly take back to colleagues, for example, in Affinet, in case there is someone in that kind of network, international network, who is interested in perhaps taking that forward.
Thank you, Lorna. The next question asks, what can we learn from your work about supporting staff working in services that support people who have experienced severe and multiple disadvantage, who will frequently be experiencing deaths associated with substance use?
I think some of that goes back to what I was saying, and the previous question indicated that there is both an absence of, but also a need for support for staff. I think perhaps the key thing that we need to learn is that it is a big issue. I think perhaps that's the first step, is to raise awareness that these are deaths that are sometimes happening on a too frequent basis for staffs and services and organisation, and there needs to be that original, that awareness to start with. I think, until you have that awareness, you don't really have the capacity and the buy-in to be able to build on that, to be able to do something about that. I think services and organisations can consider what they can offer in-house. So maybe wellbeing support, ensuring that there is access to internal counselling, but perhaps also funding to support access to external, perhaps more specialist counselling, including grief and maybe trauma-informed counselling as well, where it's needed. Perhaps considering kind of offering or buying in training, perhaps around trauma, to help raise awareness across a whole organisation of the potential impact on staff and on clients. And I think as well, perhaps the firm, slightly tangential point, but it's still relevant, I think, is it's not just going to be those staff who perhaps are the direct workers who are going to be affected by these deaths. It can go for all levels of a service and organisation, from kind of admin, HR staff, IT, right up to those that managerial and operational chief exec level as well.
Thank you, Lorna. The next question asks, how might addiction show up on a coroner's report?
So varied, I would say. So coroners they have a number of what are called short form conclusions that they can kind of draw on at the end of an inquest. For example, death by misadventure, and so on. There is a drug and alcohol related death kind of category that they can draw on. I don't know, there would be variation, I guess, in how the coroner and the medical profession would agree on what goes on the final medical certificate of death, and if and how any involvement of alcohol, like or other drugs, or indeed gambling is included. So I would say it's, it's widely variable. There is that option to them, but there is also, we hear of examples where families want it to be named because they want the statistic there, because they have the hope that by doing that, the death is going to mean something somewhere that will finally lead to the change that is needed. But we also hear from families who don't want it to be named and might potentially proactively ask if it can't be included because they don't want the shame and the stigma, and there can be conflict within a family as to how open or not they want to be about how the person died.
Thank you, Lorna. The next question says, you mentioned anticipatory grief. I wonder if the guidelines also apply for these experiences.
I'm not quite sure what the question is referring to. So the guidelines that we developed and the 5 key messages that came from the research do include consideration that the professionals who come into contact with bereaved people need to have at least the awareness as to what a bereaved individual may have been living with and experiencing before the person's kind of died. They're not just going to be affected by the death. They may have been affected by months and years of kind of upset and trauma and kind of difficulties, which can include their sense of, anticipatory grief. I'm not sure that necessarily answers the question. As I said, I'm not 100% clear of the question, but I hope that goes some way to kind of offering a response.
Thank you. And if whoever did ask that question, if they wanted any points clarified, if you just pop something else in the Q&A box, and then we can come back to Lorna with that as well. So the next question says, can we generalise from your research into the response to families' responses to bereavement after substance use to staff?
Sorry, could you repeat the question?
Yes, sorry. Yeah, no, that's okay. So it says, can we generalise from your research into the response to families' responses to bereavement after substance use to staff?
Yeah, so would our findings with bereaved people with the same kind of themes be seen if you talk to staff? I guess to a point, yes, but again with variation, because obviously, the key variation is the nature of the relationship. But it may have been, actually, I remember for some of the interviews we did for Voicing Loss were with prison officers, and actually also people from substance use treatment services. And, some of them talked about perhaps for example, in the prison service, the sort of daily contact that they would have and the relationship that they would build up with someone who subsequently died, and a relationship that is very different to the relationship that prisoner might have had with their family. So I think it's, you know, again, I think that's a gap where there is a need for more research to explore the extent to which something like our findings could be applied and where there may be difference. But I think I have to think how I articulate this. We also found from Voicing Loss that some bereaved families can be resistant to the idea that a professional may be grieving in any way that's similar to the experience that they have as a bereaved kind of relative. So I think there certainly would need to be work to be done to communicate the messages about how staff may be bereaved and what that may be grieving and what that might, you know, mean, that does not detract from the experiences of bereaved people. Yeah, we had some, you know, bereaved interviewees who just didn't understand why a professional was upset and felt that perhaps they didn't have the right to be upset. That's all on them as a family. So, you know, there's a lot to unpick there. I think there are findings that can be generalized, but I think it's a more complex piece of research that would need to be undertaken and then communicated.
Thank you. We'll just go back to the previous question because the person who asked the questions just come back with some clarification. So this was around anticipatory, and the person who's asked the question said, I meant that staff would also experience anticipatory grief, and I was just wondering about the support for staff around that, as in staff would also often be supporting someone whilst they are in a palliative stages of substance use, and whether there is research that can provide insights into how to support staff whilst doing this. I work in rehab teams, and my questions directly relates to my own experiences of what has happened to my sister in another London-based team. It speaks to issues with links with housing, mental health teams, families and service users.
Yeah. So, I mean, I think I've covered that there is, you know, again, it goes back to the need for further research to properly unpick staff experiences, linked to anticipatory grief, work with palliative and end-of-life care, where there is a death and impact afterwards, and then where there is a need for staff to be involved in things like internal investigations, which can be very difficult as well as things like perhaps police and coroners' investigations. I could also, so there was another piece of work I was involved with, which I didn't include in the presentation, partly because I didn't think I'd have time. Again, 8 to 10 years ago, it's kind of really hard, isn't it, to still think of exact timings as when things happen, particularly in relation to COVID. But so it's a piece of work. It's funded by the big lottery. It was led by Manchester Metropolitan University. The lead investigator was Professor Sarah Galvani, and that was a project that focused on end of life and substance use, and did develop like a range of kind of guidance and other resources. And I think I was involved in that original piece of work for the families work package, but I do understand there has been other work, particularly focused in the Northwest, to take that strand of work forward. So that kind of may be something that you're I'm sure a kind of Google search perhaps for Sarah's name, or substance use and end-of-life care kind of research, perhaps in the Northwest or the Manchester and Liverpool areas, may come up with something that could be useful. So that's Professor Sarah Galvani, Galvani. She, I don't think she's at Manchester Metropolitan anymore, but I'm sure the research will still come up. I will have a look and see if I can find a link, perhaps more kind of quickly find a link that I can send to Justine afterwards.
Yeah, thank you. Yeah, that'd be great if you could, Lorna. Thank you. So we've got 2 questions. They're from the same person, but I'll read them separately because I think that'll be easier to do it that way. So what support is there for families where there have been failings by housing and mental health teams that may have contributed to their death indirectly on a psychosocial level, or poor information on discharge, planning and communication, provision of support? And then it just says, where said person has been put into temporary accommodation for over 18 months and work on their property not completed or remedied in this time, which has contributed to their destabilisation in mental and physical state. I'm not sure, did I read that okay? Did you understand?
Yeah, no, and I can, so that is in the chat rather than your Q&A box, so I can see that. I'm going to be honest, that's too specific a question for me. I don't have specific enough knowledge, perhaps linked to substance use and maybe housing and mental health specifically, to think about that. So I'm not sure I'm able to really kind of offer anything to that. So I'm really sorry to the person who asked the question.
Thank you, Lorna, for saying that.
I haven't really done any work in terms of housing and so on, so it's it's maybe come up tangentially in the work I've done, but I'm not really sure I can offer anything, so sorry about that.
No, thank you for saying that. And the next point is from the same person, but a different question, which may be more around the work that you've been doing. It says, can we query and ask for more information pertaining to SUDAM on coroner's reports?
So what's SUDAM? I don't know the acronym.
I don't know the acronym either. It's SUDAM.
Yeah, I can see it. And if the person is still in attendance, could they just clarify the acronym? And just while they're doing that, if they can, thank you to the person who's been very helpful and very efficient and has put a link to the Manchester Metropolitan project that I talked about, and which may be an additional I'm gonna open kind of that up so I can send you the link to that, Justine, and ask you to send that around to people with my slides and one other link as well. Yeah,
lovely, thank you for that, Lorna. I was just seeing if I could find out what the acronym was for.
Does anybody else know? Perhaps the person
sudden unexpected death in substance misuse.
Yeah. So they want clarification, asking for clarification from me about how that's. I don't think. I mean, I don't have enough detailed knowledge of the inner workings of a coroner's investigation and inquest and how they take the information that they get to prepare their final report. So I'm not sure I can answer that. Either. I mean, what some of you might want to do is, I don't know where you all are geographically, is you may want to engage with your local coroner service, and actually, if there isn't a conversation going on, it might be worth considering whether local coroners teams would be interested in having conversations about how they maybe things they take into consideration for these types of deaths, and whether there is a scope for conversation to help kind of educate them, so like a reciprocal information sharing process may be helpful.
Yeah, that's a good idea. Thank you for that, Lorna. And that's the end of our questions now. So yeah, thank you ever so much for presenting today and the responses to the questions that you've given. And thank you to everyone for attending and your contributions and questions for Lorna.